Good morning, everybody, and welcome to this webinar, ASH webinar on building the business case for the CURE model. I'm Hazel Cheeseman. I'm Deputy Chief Executive of ASH. I'm going to talk slowly through the first part of my slides as we wait for some more people to join and kick this session off. So I'm just going to run through the agenda, which is relatively straightforward this morning. I'm going to do a short introduction, and then I'm going to hand over to Dr. Matt Evison, the clinical lead at the Making Smoking History and Cure project over in Greater Manchester. And so the bulk of today's session will be from Matt talking through the CURE model in GM and how they've built the business case there and the evidence that they've generated from the work that they've been doing in GM. And then we'll have some time at the end for questions. Apparently I'm going to make some closing remarks, so we'll find out what those are when we get there. Okay, a little bit of housekeeping. So this meeting is being recorded, and a recording of the event will be circulated to everybody afterwards, along with the slides. So you'll be able to share those with colleagues if you think that would be useful to other people. All panelists, that's basically you, Matt, you need to keep yourself muted, otherwise we'll mute you. Please do submit questions in the chat. So we've got plenty of time at the end to answer questions. So do use that chat function and add questions there. And if you've got any issues at all, you can either use the chat function, or if you email our admin address, the Smoke Free Action admin address, then we can get back to you that way. Okay, I'm just going to do a few introductory slides before we get to the main event with Matt. So just to kind of reiterate things that hopefully we all know, but sometimes it's useful to just make sure we're all on the same page. So of course, this work that we're talking about here, the Tobacco Dependency Treatment Programme, part of the long-term plan, is intended, kind of clues in the title, it's intended to be long-term. So the programme requires full implementation by 23-24. I'm guessing if you're on here, you know that. And you know, funding has been allocated to secure that. And the expectation is that funding is going to be reoccurring. But we know, because we're hearing from people out in the field, that there continues to be some anxiety out in localities about the reoccurring nature of this funding and what kind of assurances can come from the centre. But it's a really tricky context. I mean, I think this is often the case with the NHS, that budgets are often confirmed, pretty close to the start of the financial year. And we're in yet another round of the NHS budget being political football. Here's a headline from the Health Service Journal just from this week around the Chancellor looking at doubling efficiency targets. And so we're still in a position where these budgets are unconfirmed as we move steadily into March. So we're in this tricky position where it's difficult for the centre to confirm the specifics around this particular part of the budget when there's this big kind of political context over what's happening with the broader NHS budget. But what we have to remember is that we can't wait forever to keep our programmes moving forward and get them implemented. If we're delaying implementation, then we're risking not being able to meet that 23-24 target to have these services implemented. So we really do need to get going. Just moving on to my next slide. So building the case locally. So in the context that we do have this money, we've got this requirement, why might we still need a business case locally? Well, trusts possibly need these business case to kind of cover their own internal needs. So trust might well want to review the costs versus the income of each project, and to assess the risks and benefits of this particular program. And I've linked here, hopefully again you guys have found your way to the NHS Future site. There's a bunch of information already there which could support making business cases, and the session today is really going to hopefully add to your understanding around particularly the case in Manchester. So building the business case isn't just about that kind of bureaucratic ticking the box for the trust. It's also really important that we're securing leadership and buy-in for this project, because we know that that's a key requirement for projects being successful, is that corporately organisations are bought in from the top, particularly when we're talking about doing something new, and clearly implementing the tobacco dependency treatment programme is quite new for many trusts and in many contexts. And it will protect it into the future, as you know, the expectation is that this money is reoccurring and comes into baseline, but clearly these things can be buffeted by local decisions. So the stronger the business case can be from the outset, the greater the buy-in that we can secure into the future. So I'm not going to steal too much of Matt's thunder, but I just wanted to reflect on, in broad terms, about what this business case is. What are we talking about? And you know, I'm sure I'm preaching to the choir here, that you know, if we can implement the tobacco dependency treatment programme, we can deliver much better outcomes from other treatment. You know, smokers will you know, have all sorts of complications and problems with treatment being less effective if they continue to smoke, that can be averted if we can get them to stop. Clearly, addressing health inequalities has become an increasingly important focus for the NHS, and smoking is absolutely the biggest driver of the difference in life expectancy, and mustn't be forgotten, and needs to be at the heart of those health inequality approaches. And also, this is just the basic kind of human right that, you know, we can add quality of life to people even when they have a terminal diagnosis, if we can help them to stop smoking. But I think that it's important in this context of so much pressure on the NHS through the pandemic to remember that there is this really strong case in terms of the demand for NHS services, and not to forget social care services too, if we can reduce smoking. So the impact in the short term in terms of, you know, CVD, infections, respiratory exacerbations and so forth, but also in the longer term as well around cancers and other things. And I've put here a picture of the, you know, the stuff around NHS waiting lists. You know, the opportunity to kind of make to find virtue in our waiting lists and really help people who are on them is something additional that we might want to think about, this sort of pre-ablement agenda, not necessarily being delivered through the NHS long-term plan, but how we can use these resources to help people so that we are reducing the burden on the NHS longer term. And then just a little bit more of the kind of strategic context. You may be familiar with this strategy, the Core 20+5 strategy, developed by NHS England Health Inequalities team. And it talks, for those of you who are unfamiliar with it, the Core 20 is the 20% most deprived part of the population. The plus represents these sort of health inequalities type groups that experience particular disadvantage in relation to health outcomes, and then 5 of these 5 clinical areas of priority. And smoking, you know, is integral to each element of this. You know, it's more prevalent in our 20% most deprived, it's more prevalent in most of our kind of health inclusion health groups, and it links to all of the 5 areas of clinical priority. So, you know, absolutely core to this kind of new strategic approach to health inequalities. And then we've got new NHS operational guidance for 22-23, which specifically requires prevention plans and also links to the delivery of tobacco dependency treatment. So, you know, we've got this strategic context, which is really important. So just quickly to summarise, you know, we have the strategic direction through the long-term plan. We've got things like the NHS planning guidance for this year, which says we absolutely need to do this. We have new money. We can just crack on. But clearly, trust might require a case for local governance and due diligence to make sure that the project gets taken forward, and hopefully this session will give you a bit more in terms of the business and clinical arguments for that. And just before I hand over to Matt, I'm just going to nod to a few things that Ash is hopefully doing to kind of support this agenda. So we've got some briefings that we're hoping to publish in the coming weeks, which will be for each ICS. It will link to that Core 20+5 framework and provide data on an ICS footprint for how smoking is influencing or impacting on the different aspects of that Core 20+5 agenda, and then calling for the implementation of things like the tobacco dependency treatment programme in order to address that. We've got these slides will be circulated. There are some links in here. So the existing information that we have around the cost of smoking and inequalities dashboards, which you can find, they're broken down to local authority level, but may still be useful in helping you to make the case. And then we've relaunched the NHS Smoke-Free Pledge. Some ICSs have already signed up to this, which has been extremely welcome. And this is an opportunity for NHS leaders to show their commitment to tobacco. And we'll provide this link and you can see a bit more information there. And then in the coming months, we're hoping to produce a new briefing, kind of linked to that pre-ablement agenda around smoking and surgery. Rehabilitation, I don't know what I just said then, sorry. And then we're really keen to hear from you as well going forward about what further resources and webinars you might like from us to help support you. Right, so on that, I shall stop. Please do remember to add your questions into the chat. And without further ado, I shall hand over to Matt, who hopefully is going to be able to share his slides. Brilliant. Over to you then, Matt, and we'll come back in the Q&A for further conversation.
Thanks very much. So I just want to check, Hazel, that my slides are sharing.
Yes, I can see them. They're in the they're not in a presentation mode. You might want to click the presentation mode.
Ah,
that's
how's
it.
that?
Yeah.
Yeah.
Brilliant. Yeah.
And is that moving along?
It is, absolutely.
Perfect. Okay, great. So thanks very much to Hazel and to Ash for inviting me to speak. And really, it's been putting these slides together has been quite a reflection of the journey we've been on in Greater Manchester with the Cure project over the last 4 or 5 years. And so I'm going to very much frame my presentation around that journey. Because we've been involved in quite a few projects where we've followed this basic pathway where the research is always the first area to demonstrate the effectiveness of an intervention. But then that is only the first step. Once there's an evidence base of clinical effectiveness, that then has to be translated into a real world clinical service model. And it's really important to then demonstrate real world outcomes from implementing that service and then take that implementation and pilot work and move it into something that's sustainable, resilient, that's resourced and can be upscaled. And this is true really of any healthcare service pathway to reach that point of routine commissioning. And that's where we want to get these services to, and that Hazel's already mentioned. And those real world outcomes, the 3 areas we've focused on and that I'm going to talk about today is having clinical effectiveness, cost effectiveness, and also importantly, demonstrating the experience of care within that service. And really, at its heart, showing that patients want this. I think that becomes a really powerful message in a business case, in a discussion with a senior leadership team at a hospital, at a regional level, in an ICS, to say we have a program that we can demonstrate clinical effectiveness, cost effectiveness, and that patients want it. That becomes a really very, very strong argument. So in terms of Cure, our pathway, our journey along that pathway began with the evidence base for clinical effectiveness. And really this, it was very much a hook. We needed something to get people's attention to say, actually, it's right to start down this journey of translating into a clinical service model, of going through a pilot phase. And for us, that hook was very much based around the Ottawa model. And that's what I'm going to kind of show 3 slides. And I must have shown these slides probably thousands of times in presentations that I've done, but particularly at the outset of this journey, when we're first meeting with a chief executive to say, this is what we want to do at the hospital. So secondary care is a really important place for tobacco dependency treatment for a number of reasons. There is a concentrated population of smokers because of all the smoking related illnesses. So any given day, there's about 20,000 smokers in a hospital bed around 1 million smokers admitted over the course of a year, and you're 36% more likely to be admitted to hospital if you smoke. So that in terms of providing a service and footfall through a service, a hospital grounds is an exceptionally concentrated population of smokers to be able to provide access to treatment. We've got some good evidence that it's an important moment being admitted to hospital. There's every single person knows the risks of smoking, but the moment when you can actually relate that to a health condition and an illness is an important moment, an opportunity for behaviour change and to instigate treatment. And moving someone into a period of forced abstinence during a hospital admission away from their normal cues to smoke can be a very powerful moment to start treatments that then could potentially progress after being discharged from hospital. It's really important that we when we start treatments, there's no better environment than a hospital site, because you're seeing someone on a daily basis, and you can monitor the impact, you can change things, you can support someone. There is no other environment like that. I don't really have time in this talk to talk about how effective the treatments we have are, but there are more treatments than ever before that are highly, highly effective. That's never been in doubt, and many we've had for long periods of time. But now it is all about how we get those treatments to as many people that smoke as possible. And there are immediate benefits. And this was one of the key things, the hook I was talking about getting people interested in this, was all about the immediate benefits, because it's often perceived as it's talked about as prevention, or that those benefits are reaped years in the future. And for certain things like cancer, that is very, very true. But you cannot overlook that there are some very immediate benefits to the person, to the hospital, to the system, to a whole system. And that's exactly what we did in terms of using that published evidence of clinical effectiveness. So in Ottawa demonstrated that providing very good tobacco dependency treatment in a hospital setting and supporting someone after they go home halves that person the chance of dying in the next year, and significantly reduces readmission rates. That is huge data. And so we took that data and applied the same relative risk reductions to the data in Greater Manchester, and could say, so we know what our number of adult admissions are, and if we took a conservative estimate about smoking prevalence of patients being admitted, you could then take the same relative risk reductions and say, this is the number of admissions we'd save. At this time, this is the number of lives we'd save. You could match that to an average cost of admission, the average number of bed days. And that really, really started to get people's attention with all the pressures on NHS resources. And so, we've got decades and decades of data of how effective it is to help someone to stop smoking. But this evidence of clinical effectiveness was the hook we used to get people interested to run with a pilot implementation. But I still think this is relevant now, and anybody can do this with their own data, whether it's a hospital-based data, whether it's a regional-based data. When you're building that case to say, right, we are doing this for this reason. One of those is we've got a well-designed study in Ottawa, and it's well worth reading through the detail of the paper about how they matched patients to understand comorbidities in a pre-implementation group and a post-implementation group. It's a well-designed study that showed these reductions. We have every reason to believe in a similar healthcare service, we would reap similar benefits. And anyone can do that and calculate the admission savings, lives saved, and present that within any form of a business case. And it isn't just Ottawa, there's other data out there. South Carolina done a huge study of hospital-based tobacco dependency, and shown good quit rates at 30 days. Remember, these are intention to treat quit rate. So it's every single smoker admitted to hospital as a denominator, whether they accept treatment or not. And that's a very different population to those actively seeking a stop smoking service in the quit rates. This is looking at the whole population admitted that smoked to a hospital setting. And Nottingham, the team in Nottingham, John Britton and Rachel Murray, had done a brilliant study in the UK looking at opt-out services in hospital, showed excellent rates of uptake, follow-up, and really excellent quit rates. So the data is there of clinical effectiveness of hospital-based interventions with really rapid benefits to everybody. And so that the next step in that pathway is then translating that into a clinical service model. And that's where the Cure project started, to take that model, translate it into a clinical, real life clinical service model, not a research trial, but how would we deliver this at scale across a hospital system? And I've said many times about Cure that we've managed to successfully reinvent the wheel, because there is nothing new in there. As I said, the effectiveness of helping someone to stop smoking, the evidence base is huge and very, very long standing. The treatments are well established, very effective. We have to get people access to treatment. We have to get people access to specialist support. But it's just, how do we do that in a hospital environment? And why was it good to, in many ways, reinvent the wheel? Because it was, I think, about a new start. And that's very much around branding, around a new name, around a new approach, to give this over impression of, right, we're doing something different now. We're changing the way we do this. And the branding and the name was very purposeful about medicalizing tobacco dependency. So there's such an opportunity. And it really reflected how I started to think about tobacco dependency, and that it had not been within the remit of clinicians before. I used to think I was very good for asking people if they smoked and telling them that I think they should stop if they did. But that was about the limit of my interventions, when actually we've got so much ability to talk in depth about tobacco dependency and talk about the treatments available. And that medicalization into a disease felt like the opportunity to reinvigorate and start something new. And that disease process, then it brought it very much into a hospital-led service. And maybe traditionally that's something that hasn't been done before, with a hospital team taking ownership of this, being a nurse-led service in a medical environment in the wards. Again, supporting that, we're starting to do things differently as a medical team, nurse-led, that delivers medical interventions as well as specialist support, building that brand, and using that to try and attract the workforce to want to work into that, and having some strong clinical leadership at consultant level to try and drive this forward, where we would provide treatment to inpatients when they're admitted to hospital, but also follow them up afterwards and provide the treatment after their discharge. And that was our pathway to set up electronic systems that would capture the smoking status of every patient admitted to hospital, and everyone that was identified as a current smoker to be automatically referred to the Cure team, where they would be approached opt-out basis, offered specialist consultation, behavioural change support, pharmacotherapy, and that team would follow them up after discharge. But actually, a real key part of it was empowering the admitting clinicians with the knowledge and the competence and the confidence to provide brief advice, to understand the treatment, to commence treatment, to really have the clinical team playing a key part in that pathway, and training them to do so. And this is just a really quick screenshot of some of those electronic systems. That our admission document in electronic patient record had a simple smoking status screening question, but if that was selected at yes, it moved a patient into a Cure list for review. But it also then triggered a couple of simple questions that would define what NRT needs to be prescribed, and the recording of brief advice and treatment provided. So we're starting to capture good data around it. And that became our pilot phase that we ran over a 6-month period, and from the success of it, we business case that to be recurrently funded, and it's been recurrently funded to this day. We started it in 2018, with hiring 3 specialist nurses for this pilot phase, and we're now up to 13 specialist nurses that provide inpatient, outpatient, lung health check, tobacco dependency treatment. It's grown and grown and grown. But that pilot phase was built off the evidence base and then a new clinical service model. And so thinking about those real world outcomes to build a business case, clinical effectiveness, of course, comes right at the top. And we were able to show through good data collection. And I think because we had the delivery of both the inpatient and outpatient components of the pathway, really good data from admission to follow-up, that our electronic systems capture the vast majority of patients in terms of a smoking status. And our admitting teams are doing well. They're giving a brief advice to 96% of people identified as a current smoker. And if we approach everybody, 61% of them accepted specialist support from the cure team. And across both the admitting team and the cure team, there's almost 2 chances to prescribe pharmacotherapy, 2/3 of people being prescribed pharmacotherapy. And ultimately, at 12 weeks, 22% being abstinent from tobacco. And that's a huge amount and that again is on an intention to treat basis. And if there are 1 million smokers admitted to hospital over the course of a year, and that could be replicated, that would be over 200,000 people stopping smoking and all the health benefits associated with that. And we, again, as I say, because we owned that discharge pathway, there was good uptake of follow-up afterwards. So at 2 weeks, 4 weeks and 12 weeks, I had 46%, 49% and 33% completing that follow-up with those quit rates of 21% and 22% at 12 weeks. Just adding to the table I was showing earlier, where there was clinical effectiveness largely based within research, we've now got real world data to show that this can be implemented across a hospital system, not in 1 ward or 2 wards, across a whole hospital system, with good evidence of uptake and quit rates, particularly in context and in comparison to those published figures. So cost effectiveness then becomes really important. So we've shown it can be clinically effective, but the money that is spent to deliver that, is that an effective use of NHS money? And so we've done a cost effectiveness study, and this has just been published in BMJ Open Respiratory Research, where we've looked quite in detail at the costs of the programme. And we've got a good grasp on the costs because we know what the pharmacotherapy costs were in the hospital. We know what the salary expenditures were. The one, excuse me, the one area where we had to estimate costs is about the cost of additional pharmacotherapy after discharge. A lot of our follow-up was remote and telephone, and was reliant on the community GPs prescribing the ongoing medications. So to understand those costs, we have the baseline money that was spent on stop smoking pharmacotherapy within our locality, and there's a very clear uplift as soon as the cure project starts, and we can understand what that uplift is and therefore estimate the expenditure on those medications. So that 6-month pilot with the costs came to just under 100,000. So a small real investment for what that service delivers. And we can have quite a good understanding about how that breaks down. So it's about £40 per patient for the hospital intervention. Remember, that covers the cost of inpatient support, inpatient pharmacotherapy, and outpatient support. And we understand the average amount of medication spent on discharge, which was £97. And that meant we could calculate the cost per quit, which was £475. And what's useful with that is there is data out there, published data about community stop smoking services and how that matches up. Excuse me, sorry. Because that's when business case discussions happen and we're asking for significant funding, there's always, well, so if we allocate funding here, Does that mean somewhere else loses out? And how do we make those prioritizations? And actually with figures, it can be, well, show me where investment might elsewhere go. Is there a cost per quit if it's a tobacco dependency service? Is there a cost per quality, which I'm going to go on and show? Which means you can try and really start, it doesn't become a, well, should we spend this here? Should we spend this there? It becomes a much more objective discussion with actual figures behind it. And then for cost effectiveness, we used a really well validated, very well established tobacco dependency tool, the Equipped tool, and also a tool that's used in Greater Manchester for any transformation program, so it can compare impacts across those programs. And these tools calculate treatment cost savings for some of the key diseases, not every disease. So these are only key diseases, so it will underestimate the health benefits. It will calculate a cost per quality, and it will calculate a return on investment by various different figures, both fiscal and on public value. And these become then really important in the business case arena. So if this is £1 invested, you can expect, based on a real life data of this service, this much returned in fiscal value, and the public health return, £30 return for every £1 invested. And the cost per quality, £487. How does that measure up to other investment opportunities? If you're looking, at large scales across systems about where investment goes, this data becomes incredibly powerful.
Matt, and then sorry, if I just ask you to speed up through your last few slides, if that's all right. Cheers.
The last bit of piece of the jigsaw is the experience of care. This is entirely new data. We've just got this in submission. Just to say, we've got to be able to say that this is what patients want. Treatment in a hospital approached on an opt-out model. And we've got now data to say that our patients within this service know that the hospital admission is an important moment, are absolutely agreeable. It's acceptable to be approached on an opt-out model, that it impacts how they're thinking about their smoking, and that they receive a very good experience of care. And so we've built the business case: clinical effectiveness, 22% abstinence rate, cost effectiveness, £487 per quality, and experience of care. It's what patients want. And it then becomes about the sustainable, resilient, scaling up process. And these figures then help with that. We understand the costs. So what's it going to look like if we do this across an entire region? And that comes out as big investments. It's going to be above what is required for the long-term plan. But it's built on sound evidence of real-world data. So this is what, to try and replicate the same service, the same outcomes, this is what it would take. And actually the return on investment can be calculated. So it may be a big investment, but the return on investment becomes huge. And public values returns of 458 million is a very significant figure built on real data that is very powerful in those conversations. So that's the reflection of the journey we've been on, from the evidence base, and we can still use that now. Any teams can use the Ottawa data to say these are things we could be saving that isn't accounted for in those cost effectiveness analysis, in terms of readmissions, in terms of mortality. We've got clinical service models, and everyone is doing this now and developing the models of care that serves their institution and region the best to provide this treatment for inpatients and after discharge. We've got clinical effectiveness, we've got cost effectiveness, and they can all be used to build the business case for, because I absolutely believe more investment is needed on top of long-term plan funding. And it's just a real plug that I think that regional tobacco programs are the perfect infrastructure to help with this kind of regional business case view and developing those funding discussions at scale. So thanks very much.
Brilliant, Matt. That was great. I learnt loads through that presentation, and we've got lots of questions, which we may not get to all of them. So we'll have a crack. I'm going to start with a couple that are about how you about the savings that you were talking about. So Andrew and Devon asking about the question that they always get, particularly with the pressures within hospitals is how do you release the cash from the savings evidenced, and follow up from Corinne kind of saying, yes, the savings are going to come, but with trust so stretched now, how can they invest in advance of savings? And then also she's saying, when the LTP funding isn't really enough to introduce the whole package. So I don't know if you could respond to those two questions to kick us off.
Yeah, it is a hard one, and I don't profess to understand the details of cashable fiscal savings versus fiscal savings. And I think ultimately those kind of discussions come down to senior leadership teams, directors of finance, but supported by the clinical leaders to voice these benefits. And that is hard for a hospital system. Those public value returns are there's just nothing that rivals those. Mm. It's very hard to put those into this will save the hospital that amount of money. Mm. That modelling is incredibly difficult to do, to say, well, it'd be this number of coronary artery angioplasties that this is saved. Well, we don't do those coronary artery angioplasties. It's done by the hospital down the road, so we won't save that. It becomes so complex that you just become cross-eyed. But it is not. I think if what there is granularity about now, I hope, is that we're not just saying, oh, do you know, it does really save things down the line. It's putting numbers and figures that is based on something. It's based on these figures, but this is UK data, and it's real life data. Yeah. It's not with the support of a research team or anything else that gives us the power in those arguments to put them forward. And so if you say, well, why invest in this? And get faced with questions like that quite a lot. So, well, show me what you're going to invest in alternatively. So show me the quality and show me the return on investment. And then you're justified. I'll sit back and pipe down. If you say, well, actually, so there's a program here with a quality of £380 and it saves this. Yeah. And it does that. And you can, it becomes a much more subjective discussion. Now, if you can't show me those things, why is the system not investing in this at scale? Because you're saying that the savings are the most important. We've got to be as efficient as possible. And I'm giving you a return on investment.
Well, and I guess this is back to what many of the other questions are also about, which is about senior stakeholder buy-in and how that can be achieved, and who do you need to get on board? And yeah. It'd be good to hear your reflections on that. But I also wonder, you're a clinical leader. What was the thing that kind of turned you on to this agenda and made you kind of sit up and go, gosh, I need to spend all of my life working on tobacco treatment dependency?
So I do a talk that's called The Medical Management of Tobacco Dependency, From Negligence to Excellence. And it's a really inflammatory title. As soon as you start to talk to clinicians about negligence. But I'll always qualify it because it's an absolute reflection of my own journey. So, I look back, and I'm a respiratory consultant with a specialist interest in lung cancer. So if anyone is going to be engaged in a tobacco control program, it should be me. And I look back and think, even as a consultant, I'd probably, if someone had asked me and said, so are you do you do everything you can about tobacco control? I'd be like, yes, yeah, absolutely do. Because I ask all my patients if they smoke. And if they do, I tell them that I really think they should stop. And I agree. But I look, in all seriousness, look back and think, I had no understanding about how you should prescribe and counsel someone on NRT. I knew the word Champix. I didn't know what drug it is. I didn't know how it works. I didn't know how you prescribed it. I knew there was Zyban as well. Same thing. Didn't know anything about it. I never knew nicotine was not the cause of the illnesses of smoking. That's as a consultant respiratory physician. And then, so it's a real realization of there's so much I can do, so much more I can do. And then you start to see it in practice, and you start what can be, sometimes you approach the conversation and think, in your mind, you're having a consultation with a patient, you always know what's coming, you're going through a process. And you think, oh, smoking's coming up next, I've got to ask them, I hope that goes all right. Or, a slight apprehension about bringing it up. But actually, when you've got the skills and the knowledge that empowers you to have a really good conversation with someone, and someone turns around and say, no one has ever talked to me about it like that before.
Yeah.
I never realized this, never realized this was help. And you see them a few weeks later, this app, they'd stopped and we've done this and it works. It's so gratifying from both aspects, from a clinician and from a patient's perspective. And you think, wow, it's so simple. It's so cost effective. You start banging your head against the brick walls. Like, what were you doing for years? And then why is it like that? And why is it across the system? And so, and when I start telling those stories and start presenting, you get the same people having those same reactions and thinking. They come up to you after a talk. There's nothing nicer than doing talks on treating tobacco dependency, because afterwards people come up to you and say, never knew those things. That will change how I practice from today. So, and you just think, why does everyone not think like this? And why does that?
How do we bottle your experience? How do the people on this call go out there and win their clinical champions over, win their senior, get the clinical champions on board, get those kind of,
I think it's empowering clinicians that to have this really proactive role in an area everyone has felt apprehensive for years. And actually it's because we don't teach it in medical schools. It doesn't go back to grassroots so that everyone leaves medical school with this really solid understanding of tobacco and how to treat it. And as soon as we empower people and they start doing more of it, it really sparks an interest. So I think it's actually the understanding of the disease itself and how we treat it and how well we can treat it. For years, it's just been like, well, smoke. If you want to smoke, you smoke. What can I do to change that? That's that person's
really challenging
choice.
that fatalism and getting people to
really.
And we talk about tobacco control being addictive. Like, none of us can ever leave it.
Yeah, so. Because you start to realise, you think it's so simple. It's not. It's the healthcare spends so much money on the latest technologies, robotic surgery, all these brilliant things. And the biggest thing that would make a difference over anything else is £30 worth of NRT or a course of Champix or a vaping kit. All these things, they're so simple, but so effective. It's just getting the healthcare community to be right behind that and being like, right, we're going to deliver this at scale because it'll be so beneficial. I think it is about finding that leader.
Yeah.
To take that on.
And if everybody had a Matt Evison, we'd all be fine.
I think it's brilliant to see. It is happening across the country. And there are brilliant programs. Cures is just one. It's just our program that we've done in Greater Manchester. There are so many other of them. It's all doing the same things, and it all has the same things. We need clinical leaders. I think that comes down to actually just understanding it and seeing it in action and getting the passion behind it.
And what it strikes me, Matt, as being is about different ways of telling the story. So you can tell the story in the way that you have today with the numbers and the cost savings and the quantifying the impact of that. And then you can tell the story in the way that you also have just done in that kind of the personal revelatory stuff about what it means to treat somebody, but also what it means for that smoker. What it means to have your life turned around so that you stop smoking something you felt you could never achieve. And then the doctor intervenes and your life is suddenly very different. Yeah. And bringing those different stories together for leaders, I think is what shifts hearts and minds, because different people will respond to the stat on the page which said X number of bed days, or that somebody else will respond to the story about the individual. And it is about bringing those things together to make the case. Just in our dying moments, we've got so many questions that we've not answered. We'll try to get back to you in writing when we circulate the slides and so forth. But you didn't talk that much about how e-cigarettes kind of fit with the program. I wonder if you could just say a little bit about that before we
absolutely, because that was really focused on outcomes. Now, how do you get to those outcomes? And what I'd say is that pilot was run before we now have a vaping offer as absolutely bog standard part of our treatment offer, twice as effective as NRT, hugely popular across smokers. So I know our outcomes are going to be a lot better now because our treatment has broadened and is more effective. Horrible that we don't have access to varenicline at the moment. It's such an effective treatment. That's a real, it plays on my mind the whole time. But what's important is that the the fallback then is on NRT if we don't incorporate vaping into every single aspect that we do, because that is our most effective treatment.
Yeah.
Really good published evidence.
Yeah.
So without it, we're going in with our least effective. We're not going in our strongest position. And that's the kind of the one thing you would want for every single smoker across the country is that they had the ability to have either combination RT, Champix and vaping, or all mixed together.
Yeah.
That's what we want to get to the point. That everyone gets that opportunity to have it.
Thanks, Matt. I do hope that we can identify many, many more of you all around the country to champion these new tobacco dependency treatment services. I think we'll be on to a winner. So I think we've got some more webinars coming up. We've got one coming up on metrics next week, which will be very important, although maybe you might lack the passion of today because, bean counting. And then we have a session coming up about e-cigarettes, which I'm sure will be very useful in the context of rolling out new tobacco dependency treatment programs. And then also a session on pharmacotherapy, where we will go into more detail and particularly discussing kind of alternatives to Champix. So thank you so much, Matt. I found that really, really interesting. Thinking lots of comments in the chat, also finding it inspiring and interesting. And look forward to welcoming people to future webinars, and we will close this one for now. Thanks very much.